Testing? Hear me? Okay. Good morning, everyone. My name is Dr. Wright. I am a resident physician in the emergency room, and today I'm going to talk to you folks about traumatic brain injuries. Here's my outline of things we're going to review. We'll talk about the Glasgow Coma Scale. We'll review some anatomy, the Monroe-Kelly doctrine. We'll talk about intracranial pressure, Cushing's reflex, coup contra coup injuries, both epidural hematomas and subdural hematomas, subarachnoid hemorrhage, diffuse axonal injuries, some unusual respiratory patterns you might see with head injury patients, things that we can do to treat patients with increased intracranial pressure, and some specific things for EMS that you want to know when you're taking care of these patients. And in the end, we'll do a very quick high-level overview, and then that should cover it for the day. Now, the Glasgow Coma Scale, this is something you guys already use. I'm sure you're familiar with this. But this is a great tool in the setting of head injury patients to help us kind of stratify who's sick and who's not. It's a very simple tool. There's three categories here. There's you assess the patient's eye opening, the best verbal response, and the best motor response. The best score you can get is a 15. That's a normal, healthy person. If a person is deceased, the lowest score you can get is a 3. So the scale is 3 to 15. If a patient is has a head injury, anybody with a score of 8 or less is considered to be a severe head injury. Scores between 9 and 12 are a moderate head injury, and anything that's 13 and above would be considered minor. So think about a concussion. Does anybody know what you do when you assess a patient and they're already intubated? If you're the first person, if you're doing, like, say, a interfacility transfer from one hospital to the next, and when you get there to assess your patient for the first time, they're already intubated, what do you do for the GCS? Almost. What you do is you skip the verbal section because you have an endotracheal tube between the vocal cords. They're not going to be able to talk to you. You can still assess the eye opening and still assess motor, and then you add those up and you put the letter T after it. So if a person has an endotracheal tube in place and everything else is as best as it can be, the score would be 10T. That's how you would document that. So if you're looking through another person's chart and you see a GCS score of a number with the letter T after it, that's what they're talking about. Yeah. Some things with anatomy we'll talk about. We're going to talk about some fontanelles. We're going to talk about a special area of the skull called the pterion, the middle meningeal artery, bridging veins, and the meninges that cover the brain. Here's a diagram showing all the fontanelles we have when we're infants. There's a bunch of them. The two that we most prominently often think of is the anterior fontanelle on the top of the head and then the posterior fontanelle. These others close pretty early on in life. The posterior fontanelle usually closes by 2 to 3 months, and the anterior fontanelle usually closes by 12 to 18 months of life. Before they close, if a child has increased intracranial pressure, you can see the fontanelles will bulge. And if a patient is dehydrated, you might see a sunken fontanelle. So there's things to pick up on your assessment. The pterion that I mentioned, this is a special area of the skull that represents a vulnerability. It's a place where the bones are very thin and offer very little protection from trauma. It's this junction where the frontal bone, parietal bone, temporal bone, and then the greater wing of the sphenoid bone all come together. And what's important, and let's go to the next slide here. The pterion, it's circled there, and right underneath that is a very important artery called the middle meningeal artery. And this is the structure that often gets damaged when patients have trauma to the side of the head and develop a epidural hematoma. The layers of protection that we have to cover the brain, there's 3 of them. These are the meninges. The first one is the pia mater. It's a very thin layer. Think something like tissue paper, kind of laying on top of the brain. Above that, we have the arachnoid, and then above that, we have the dura mater. Dura mater, when you translate that, it literally means tough mother. So think of it as a leathery, fibrous cap that covers the brain. And then outside of that, you have the skull. The Monroe-Kelly doctrine. Unfortunately, in medicine, everybody that's contributed likes to put their name on things. So when you study medicine, you have to learn lots of names. And I included this because I think any of you that are, I know a lot of you are probably just doing research to get CEUs, but some of you may be looking to take a state paramedic test or a national registry test, maybe FPC or CCP, and any of those sort of exams, they love to test you on the names of things. And Monroe-Kelly doctrine is one of those concepts. And the concept here is that the cranial vault has a fixed space, a fixed volume. And anything that you put in there is going to subtract from something else that's in there. So normally you would have a brain would occupy about 80% of that space. CSF will be about 10%, and blood will be about 10%. That includes both arterial and venous blood. The exception to this is if somebody has a brain tumor, then you would have another structure in there that's going to occupy space. But if you, in the setting of a head injury, if you're increasing the volume of the brain because you have edema from swelling, then it's going to push other things out of the way. So you're going to push CSF and blood out of the cranial vault. So that's a concept that keeps coming up. Intracranial pressure. This is the only math I have in my presentation today, so if you don't like math, this is as deep as it's going to go. This is the concept of cerebral perfusion pressure, or CPP. Normal intracranial pressure should be about 5 to 15 millimeters of mercury, and that's pressure that's in the skull, within the confines of the skull all the time. In order to get blood into the brain, your heart has to pump at a pressure above that level, and we're typically 60 to 70 millimeters of mercury above that. So if a person has a head injury and they start developing increase in their intracranial pressure, your body's going to have to compensate and pump your blood pressure at a higher level in order to perfuse the brain. So that CPP, or cerebral perfusion pressure, is just the driving force to get fresh blood into the brain to keep the brain working. And then Cushing's reflex. This is a really important idea. The brain is, or the body is really smart, and it recognizes when the brain's not getting enough oxygen. And the way it compensates is it says, okay, I want the heart to beat slower, and when it does contract, I want it to beat stronger and raise the blood pressure up to perfuse the brain. So the definition is widened pulse pressure, but what I want you to focus on is the increase in systolic blood pressure. So your blood pressure goes up, your heart rate goes down, and you can see irregular respirations. That's the triad of Cushing's reflex. In many ways, this is the opposite of what you guys often see with hemorrhagic shock patients. When you see trauma patients and they're bleeding to death, you know, you're going to see tachycardia and low blood pressure, but this is the opposite. On physical exam for your head injury patients, there's a few things to be mindful of. The first one here is battle sign. This is bruising that occurs over the mastoid bones behind the ears. The second is raccoon eyes. This is periorbital bruising that you'll see. Both of those are signs of basilar skull fractures. I think in most cases, when somebody's injured, they recognize there's a problem, they call EMS right away, and you guys are so fast, by the time you get there and give them the ER, you're not going to likely see those things. The situations where you might see them is if somebody fell, had a skull fracture, and they didn't call you or nobody recognized it until like the next morning. Then you might see these sort of things. Or if you're doing interfacility transfers, you might see them. Scalp locks, I included this because the scalp is very vascular, and scalp lacerations tend to bleed heavily. And I don't want you to forget to do your best to control hemorrhage in those patients, because a patient can actually go into hemorrhagic shock from some nasty scalp lacs. And then the pupil exam, this is an interesting topic. In the setting of head injuries, if a patient's developing increased intracranial pressure, you can see changes to the pupil. The pressure builds usually on one side of the brain. It puts pressure on the oculomotor nerve, or cranial nerve 3, and the pupil will dilate. When you're assessing your patients, you got to be careful though. Patients who take medicines like scopolamine can dilate your pupil. Patients who've had cataract surgery can have an unusual shape or size to the pupil. And there's a certain percentage of the population has a condition called anisocoria, where the pupils are just naturally not the same size. So when you assess your pupils, be careful. And I actually almost got burned recently. A patient came in and I saw the pupils were different size, and I mentioned it, and then the EMS provider was still there, and they go, "Oh, patient has contacts in." And when we took the contact out, it was a contact lens that makes the pupil look different. So the pupils were actually fine in that patient. So be careful when you're assessing your pupils. Cushing's, oops, I went the wrong way. There we go. Coup injuries. This is the idea that if a patient sustains trauma to the head, you have two injuries that occur. The first is the injury where the trauma occurs, and the second is on the opposite side of the brain. So if a person's in a motor vehicle that crashes into a stationary object, let's say you hit a tree, your head is going to hit say the windshield, and then your inside of your brain smashes up against the inside of your skull in the front, and then it bounces back and it'll hit the inside of the skull in the back. So not only do you have the trauma in the front of the head, you can also see hematomas form on the opposite side in the back of the head. This is something that we will sometimes see on CAT scans in the ER. And epidural hematomas, this is blood that collects above the dura mater, between the dura mater and the skull. It's usually an arterial bleed, and most commonly it's that middle meningeal artery. So patients that have trauma to the side of the head, you can fracture those bones because they're so thin, you damage the artery underneath, and then you have an arterial bleed going on in your brain. This radiologists will call this a biconvex shape when they look at the CT scan. To me, it looks like a small football inside the CAT scan. But the classic story you'll hear is that the patient had trauma to the head. They were knocked unconscious at the time of the injury. Then they wake up and they seem fine. Then they go unconscious a second time and stay unconscious. So that intervening period where they're awake and alert, we call that the lucid interval. And this is a life-threatening issue. If you come to the ER with this condition, we're going to call neurosurgery, and you're likely going to have to go to the OR to get this fixed. The good news is it doesn't happen often. It's only about 10% of our traumatic brain injuries fall in this category. Here's a CAT scan showing an epidural hematoma. For those of you that don't look at CAT scans every day, just to orient you, this is a person who's laying flat on their back, looking at the ceiling. And from your perspective, you're going to be at the foot of the bed, looking like at the bottom of the feet. So from that orientation, what you see on the left side of the screen is the right side of the patient. So this patient has a very large right-sided epidural hematoma. Notice that football shape right in this area right here. This is bleeding in the brain. And also, if you look at this, the patient's supposed to have lateral ventricles, one on each side. You can see the lateral ventricle, this large open black structure here on the patient's left side. It doesn't exist on the right side because it's been compressed. And it looks like we have a midline shift as well. So there's definitely increase in intracranial pressure in this patient. Here's another example of an epidural hematoma. Again, this is a right-sided epidural hematoma with compression of the ventricle and a little bit of midline shift. There's something else interesting on this one. In the last one, let's go back. You notice the consistency of that white area where the hemorrhage is. It's all consistent. It's all the same. In this one, we see there's some dark areas of hypodensity within the bleeding area, and that represents active bleeding. So the radiologist, when they read this, they're going to call that a swirl sign. So if you see that, that means it's actively happening right now. And here's another example of an epidural hematoma. This is going to be a left-sided epidural hematoma. Notice that little football shape there on the right side of the screen. Another thing that's interesting about this picture, if you look on the right side of the screen between the skull and the skin, there's a hematoma developing there. That's called a subgaleal hematoma. So that's going to be less concerning. That's not usually not a life-threatening thing. The epidural hematoma would be the primary concern for us. Okay, subdural hematoma. This is a collection of blood that occurs underneath the dura mater, and it's caused by damage to bridging veins. These are vessels that drain venous blood from the brain tissue up through the dura mater, over to the central venous sinus, down to the back of the head, to the transverse sinus, and down to the jugular veins, back to central circulation. So as we get older, we often have atrophy of the brain, and so if the brain starts to shrink, it makes us vulnerable to these subdural hematomas. So you got to be careful with your elderly population. Any kind of trauma to the head, you're vulnerable for this. And here's what it looks like on CT scan. Unlike the epidural hematoma that had that biconvex shape, this was going to be a crescent shape. So in this example, on the left side of the screen, you see that crescent shape just inside the skull. This represents a pretty good size subdural hematoma on the patient's right side. And here's another, I'm sorry? Go back to that slide. What is that what's that on the right-hand side? What looks like it's vertical? You know, I don't know. I got this picture off of Radiopedia, and that is really interesting, and I don't know. I wasn't for sure if it was like a drain hole or something like that. It's not drained, it's on the opposite side of the skull, so that's what I asked. Yeah, they will. When we see these things, we'll call neurosurgery, and sometimes they'll take them to the OR. Sometimes they'll put a bolt in to monitor pressure and see how they do, see if it might be operative or non-operative. But I don't know what that large missing section of skull is over there. Interesting. That's a secondary finding that I didn't focus on when I was picking pictures for this. But back to this one. This is a left-sided subdural hematoma. You see this collection of blood. It's the same consistency throughout. This is venous blood that's accumulating, and it's going to put pressure on the brain and push everything to the opposite side. So if you look right down the center where the midline is, you can see structures are shifted across the midline. You can see the right lateral ventricle, and then you see the left lateral ventricle, but it's pushed over across midline. So this patient has an increased intracranial pressure. So we're going to be calling neurosurgery for this one too. And in this picture, I just wanted to illustrate the concept of these bridging veins, and when you lacerate them, they're bleeding. So in that lower right picture diagram, that's what's happening for subdural hematomas. And then this just compares the epidural versus the subdural. Epidural, again, is an arterial bleed, usually from the middle meningeal artery. You have a skull fracture in that temporal bone or over on the lateral side of the head, versus the subdural hematoma is damage to a bridging vein. So because it's a vein that's damaged, it's going to be a low pressure system. It's going to take longer to develop. You have a little more time to before the patient goes downhill, versus the epidural hematoma. That's going to be a neurosurgical emergency. And then here's a picture. I included this because this was always confusing to me, and I wanted to make sure you guys weren't confused about it. The blood supply to the brain. When I was in college taking anatomy, we had to learn the circle of Willis that perfuses the brain. And I memorized all the names of all these arteries. And then later I was thinking, where is this? Where in the brain is this? And I couldn't remember. So I put this picture in here to illustrate that all the blood vessels that supply fresh arterial blood to the brain, they come up through the bottom, and they're essentially laying on the underside of the brain. If you took away all the other structures, it's basically stuck to the bottom of the brain. And that green circle in the middle represents the circle of Willis. It's an area of collateral circulation where multiple arteries come together and allow you to, if you have stenosis of any of these vessels, there is the possibility of having collateral circulation to get around some of these problems. And here's a better look at just the circle of Willis. So blood coming from the heart is going to come up through the vertebral arteries at the bottom, that merges to the basal artery and goes up to the circle of Willis. You also have the internal carotid arteries coming up, one on each side, and they kind of shown here in the center. Get my mouse over there if I can find it. Oh, my mouse is gone. they turn into the middle meningeal, or I'm sorry, the middle cerebral arteries. What's interesting is, and the reason I put this picture in here, the circle of Willis, where you have all these junction points of all these arteries that branch off the circle, these are places where patients could form aneurysms, saccular aneurysms, also known as Berry aneurysms. And if these burst, the patients will have bleeding in the brain, and that will become a subarachnoid hemorrhage. 80% of the subarachnoid hemorrhages that we see are non-traumatic. They're just things that happen. Patients can have an AV malformation that start bleeding, or the saccular aneurysms. But the remaining 20% are related to trauma. When patients do come in with a subarachnoid hemorrhage, they're going to complain of the worst headache of their life. And they will often be able to point with one finger and say, right here, this spot on my scalp, this is where it hurts. So when you're talking to patients and you're collecting your HPI, this is the kind of, if you hear that story, think subarachnoid hemorrhage. And on CT scan, this is what it looks like. You'll see this area of, there's the blue arrows showing it, but you have this white patchy area. That's subarachnoid hemorrhage. And again, for these, we're going to call neurosurgery. Another kind of brain injury you can have is a diffuse axonal injury. Unlike the previous injuries we've talked about where we had bleeding in different layers of the brain, this is not a problem with bleeding. This is a problem where you disrupt the white matter, the axons within the brain. So your brain is composed of a bunch of cells. They're called neurons. The business end of that neuron is the axon. And if you disrupt the axon, a whole bunch of them, kind of diffusely throughout the brain, you'll see the patient's going to become unconscious. A bunch of things aren't going to work. When you do your clinical exam, you're going to know immediately that there's something really wrong. If the patients are stable enough and they can go to CT scan, we'll take them. And when we look at the first CT scan, the CT scans often look fine. We'll do serial CAT scans on these patients over the next several days, and eventually we'll see evidence of the problem. But this is not the kind of issue that we can just take to the OR and fix. These patients, a lot of times we'll give them supportive care. So we want to prevent any secondary injuries. We'll prevent hypoxia. We'll keep the blood pressure adequately supported. We'll give them medicine to prevent seizures. And then we just support them and wait for them to get better. And it's caused by rapid deceleration or acceleration or rotational forces. Respiratory patterns. I put this in here. I don't want you to focus too much on this topic. Just know that when you're assessing your patients, most of the patients you're going to have normal breathing. You may see some odd, unusual breathing patterns, and just know that they exist. If you see these in any patients, I would pay attention to it, take note of it, and then go look it up later. So the Shen-Stokes, this is the pattern where a person's going to be breathing very shallow, and then they're going to start breathing deeper and deeper, and more shallow, and almost go apneic, and then it just repeats over and over and over. Central neurogenic hyperventilation, this is the patient who's breathing really fast, almost like a Kussmaul type respiratory pattern. And then this Biot's respiration is illustrated here at the bottom. Think of this, if you guys are familiar with EKGs and looking at AFib, and it's a little chaotic, this is like the equivalent to that in respiratory pattern. You have periods of apnea, and then you have this chaotic, abnormal, irregular respirations. But this is just one of those things. Like I said, just know that there's normal and abnormal, and if you see abnormal, pay attention to it, and you can study it later. So what treatment options do we have available? Each EMS agency is going to be different in terms of what they carry. Always going to follow your local protocols, obviously, and every ambulance service has a different formulary. But in the hospital, there's a few things available to us. Hypertonic saline is a good option. Unlike the normal saline that you would carry on your trucks, which is 0.9% sodium chloride, hypertonic saline is usually 3% sodium chloride. So it's about triple the concentration. And the concept here is we would infuse a small volume of hypertonic saline into the vein. That makes the blood very salty. And in most cases, in general, the body doesn't like to have a very concentrated solution in a body compartment. So it'll try to compensate for that. And what the body does is it pulls fluid out of the extracellular space and moves it into the blood to try to dilute that salt. And this is very beneficial for patients with cerebral edema and increased intracranial pressure because it'll pull fluid out of the brain and put it into the blood. That helps lower our intracranial pressure. Mannitol is another option to treat these head injury patients. And mannitol is an osmotic diuretic. It's a sugar, special sugar that we can infuse, and it stays in the blood. It won't cross the blood-brain barrier. So what it does is it pulls fluid, just like had a fluid shift with the hypertonic saline. We'll see a fluid shift from extracellular space into the vascular space because the mannitol is pulling that fluid in. And just like with hypertonic saline, it's the same thing. You're going to pull fluid out of the brain and get it into the vascular space. When the mannitol goes around the bloodstream and it gets to the kidney is going to see that and say, you don't belong here, I'm going to get rid of you. And it excretes it in the urine. And it continues to pull fluid with it when it's in the urine. So it's a way to diurese patients. And then the hyperventilation, I'm putting this in here, but it's a little controversial. The concept is if a patient has a head injury and they're herniating, they have a greatly increased pressure inside the cranial vault. If you have a lot of CO2 in your blood, the blood vessels dilate. And if you have cerebral vessels that are dilated, you have a lot of pressure in there. And if you hyperventilate the patient, you can blow off that CO2, you'll constrict those vessels down, and it'll buy you a little bit of space to help prevent herniation. The catch-22 here is if you have a patient with a brain injury and you vasoconstrict those cerebral vessels, what's going to happen to your ability to perfuse the brain and oxygenate the brain? So you can't win. If the patient herniates, that's a bad outcome. If the patient if you hyperventilate them and they end up getting a hypoxic brain injury, they don't win. So it's a tough place to be in. Once you're in the hospital and you get to the ICU, we are usually going to elevate the head of the bed 30 degrees. That'll help to lower your intracranial pressure. So for EMS, there's a few things to think about. The actual damage that occurs when you have head trauma, you can't prevent that. If the motorcycle accident happened, the bicyclist fell, somebody was struck in the head with a bat, once the primary injury happens, it's, what's done is done. The way to prevent those is to have people wear helmets and avoid high-risk behaviors. And you can't control what people do. So the name of the game here is to prevent secondary injury. The area of brain around the injury, you want to protect that and preserve that. So prevent hypoxia. Don't let your patients get hypoxic. Even one episode of hypoxia correlates to a negative outcome. Same is true for hypotension. For the same reasons we talked about with the cerebral perfusion pressure, if the patient has an increase in intracranial pressure, you have to increase your blood pressure to compensate for that, to keep perfusing the brain, keep the brain alive. Even one episode of hypotension correlates to bad outcomes. And then glycemic control. Anybody that has a low blood sugar, or I should say an altered mental status, you really should check the sugar. Just because you went to a car accident and you see this patient has an obvious head injury, don't assume that they're unconscious because of the head injury. They could have very well had the car accident because their sugar was low. So in the hospital, we usually target a blood sugar of 100 to 180 for these patients. And then blood thinners. This is, you guys are in the best position possible to collect this information. Patients who are on blood thinners, so it's anticoagulants and antiplatelet medicines, puts them at risk for all sorts of bleeding, and in particular, head bleeds. So if you're at the scene of the accident or you're at somebody's house, and especially if their family's there, if you can ask if the patient's on any blood thinners, things like Coumadin, also known as warfarin, or apixaban, also known as Eliquis, rivaroxaban. There's a whole list of all these medicines, including things like aspirin and Plavix. all these things are good to know. And if you know that they're on medicine, that's helpful. If you know which medicine they're on, that's even more helpful. And then if there's time and you can find out when they had their last dose of medicine, that's the best information that we could hope that you would collect for us. This is stuff that we can't get in the hospital unless we make phone calls or do some research, but you guys are in a great place to find this information out and share it with us. And if we decide we need to reverse the effects of any of these meds, the reversal is different for every medicine that they're taking. So that's why we have to know which medicine they're on. So we might be giving vitamin K for warfarin. We might be giving fresh frozen plasma. We might be giving platelets. You know, there's a host of options available. And then high yield review. This is things that you want to know if you're a person who's going to be taking an exam. Monroe-Kelly doctrine, again, this is the concept that the brain, the cranial vault is a fixed space, and you can only have 3 things in there, or 3 or 4. So 80% brain, 10% blood, 10% cerebral spinal fluid. Any increase in one is going to necessitate a decrease in the others. So in the setting of a head injury, your brain is going to be injured, it's going to swell, and it's going to push blood and cerebral spinal fluid out. So to compensate for that, your body's going to raise the blood pressure to keep perfusion going to the brain. And what's the classic history that you'll hear for epidural hematomas? Anybody remember? Exactly. Yep, exactly. Patient will have trauma to the head. They'll be rendered unconscious. Then they wake up. They look fine. This is the time that EMS might arrive, and the patient will say, "I'm not hurt. I'm fine. I don't need to go to the hospital." And then they go unconscious a second time and stay that way. So that's if you see that pattern of having a patient with a lucid interval, do everything you can to get those patients to come to the hospital, because that can be a life-threatening issue. Subarachnoid hemorrhage. What's the chief complaint? Anybody remember? Yeah, this is the person that's going to have the worst headache of their life, and they'll often be able to point with one finger and say, "This is it right here, this spot on my skull, this is where it hurts." And the name of the game, since we can't prevent these injuries from happening, is to prevent secondary injury. And we do that by avoiding hypoxia, avoiding hypotension. And I mentioned cervical spinal mobilization because anybody that's got trauma to the head, there's a high likelihood you could also have injuries to the neck. So do your best to get these cervical spines mobilized, put a collar on. I know there's some patients whose anatomy doesn't correlate well with fitting a C-collar on there, so just do your best. That might involve wrapping a towel around the head. It might be putting, a blanket roll or towel rolls, whatever you can do. Just make some effort to minimize the wear of that C-spine. And I've got a whole bunch of references. Any questions?
I'm going to give them about 20 seconds to catch up. The stream's always
Okay.
a little bit delayed.
Yeah, no problem. Yeah, I know that CT scan, I put a bunch of that stuff in there, and in most cases, that's something most EMS providers don't worry about or don't ever see. If you're doing 911 work, you're never going to see those CT scans. But if you end up working in a situation where you're on a critical care transfer unit and you're going from hospital A to hospital B, it's very possible you could end up taking patients out of one ICU to another and taking care of these kind of patients where you're going to see the CT scans. So I thought it'd be good to include that.
We take a lot of patients directly to CT, like stroke and all that.
Yep.
So we do go, we sometimes get because that happens so quickly. We'll pass them along some information.
Yeah. For trauma patients in the ER, we will always take these folks to the trauma bay and assess them first before we go to CT scan, because we don't want an unstable patient go into CT scan, you can have bad outcomes if that happens. But for stroke patients, we want to know, is the patient having a stroke and is it a bleed or is it a clot? And the best tool to figure that out is CAT scan. So that's why that's such a high priority for us.
I don't see any questions. I see several. Thank you.
Okay. I talked a lot faster today than I planned, so I'm sorry.
No, it's fine. It's fine. We appreciate it.
Okay.